Good morning, everyone, and welcome to Friday Chalk Talk. Today, we are fortunate to have 3 of the 6 researchers, writers of an article that was published in the Journal of Palliative Medicine in November of 2022, entitled Interpersonal Conflict Between Clinicians in the Delivery of Palliative and End-of-Life Care for Critically Ill Patients, a Secondary Qualitative Analysis. I'd like to welcome first, Dr. Kamal Murali. She is an assistant professor at New York University Rory Myers College of Nursing, interested in end-of-life care for seriously ill older adults across healthcare settings. Her research has focused on palliative and end-of-life care outcomes and complex care needs of seriously ill older adults. Kamal's passion for end-of-life care research is rooted in her experiences working in critical care for nearly 10 years as a nurse and nurse practitioner in neuroscience and medicine. Welcome, Kamal.
Thank you.
We also have here Dr. Craig Blinderman. He is a national leader in palliative medicine and the director of the Adult Palliative Care Service at Columbia University Irving Medical Center, New York Presbyterian Hospital, and the program director of the Bi-Campus Hospice and Palliative Medicine Fellowship at New York Presbyterian Hospital. His publications and interests are far-ranging, including early palliative care in lung cancer patients, cancer pain management, ethical issues, and at the end of life, and many other areas. He also has a strong interest in teaching and developing programs to improve medical trainees' skills in communication and care for the dying. Welcome, Craig. And finally, we have Dr. Mei Hua. She is an anesthesiologist, intensivist, and palliative care researcher at Columbia University. She is an associate professor of anesthesiology and holds a joint appointment in the Department of Epidemiology at the Mailman School of Public Health. Her mixed methods research program aims to improve delivery of end-of-life and palliative care for patients with serious illness. Currently, she is studying how differences in implementation of specialty palliative care may result in differences in outcomes in patients with metastatic cancer and other populations of patients with serious illnesses. Welcome all.
Thanks, Maureen.
So this is going to be an interview format, I think we should start with a question about arrogance and humility. There can be a tendency for palliative care to be seen as this brave new world, and we are here to show others the way. Conversations about interpersonal conflict can sometimes focus on how others don't understand palliative care or how others can have shortcomings in their communication skills, etc. How are we being arrogant in these conflicts? What are palliative care's blind spots here?
Well, I can take a stab at that one. Yeah, I think it's such an important thing to start off with. It's one of the things that I was always afraid of going into the ICUs, that I was going to be seen as somehow overstepping, bringing my area of expertise when it comes to communication skills and managing pain and symptoms to physicians and other clinicians who also have their own set of expert level communication skills and pain and symptom management skills, and they just might be different or applied in different settings. Mine often in cancer patients or with other patients with serious illness, and they're working mostly in ICUs. And so there's a way in which we have to be careful of this idea that I can do something that you're not able to do here. And so I think, for me, it always comes down to, or at least, the way I tend to look at these consults is, how can I be helpful here? Or how can our team be helpful here? Knowing that there is a level of skill and professional attitudes that, and also a relationship with the patient and or family that pre-exists my involvement. Right. So being, cognizant of the dynamics that are at play in another unit, and specifically in an ICU, which is a very intense place. And so, wanting to not assume that I'm going to, or that my team is going to bring in something that is so far out of reach that we're going to displace our colleagues. So it's really a question of, and I think it's a philosophical one too, right? Because, I think as physicians or clinicians working in an ICU setting, and nurse practitioners and MDs, may feel like this is my area. Like, I want to do this. Like, this is part of what it means to be a good ICU clinician, to run a family meeting, to have a goals of care conversation, to, talk about hospice if necessary. And so, finding, the balance, and everybody's skills are different too, right? And so there might be some of my colleagues who are like totally comfortable doing this and like don't really need that much, or they're maybe just gonna fill in one part of it. And then there are gonna be others who are like, you know what, I have a lot of really sick patients, and I don't really have the bandwidth to do this family meeting, so feel free, right? And so I think it's part of it's like reading the room and reading your, what's needed in any given situation. But I do think it's a worry if we come in. It's a worry of mine if myself or my team comes in with this idea that we're going to do it better, or we have the skill set that you guys don't have. I think that's problematic, and that's going to set you up for conflict.
I agree. We see that a lot where, the communication is the key, obviously, with that, and talking to our colleagues and finding out what it is they want for us. I agree with that. Who does palliative care serve in the ICU then? And I think that your answer kind of leads into this question. When we are thinking about palliative care advocating for the sickest patients in the ICU, we should also be thinking about palliative care advocating for our ICU colleagues, right? Supporting our colleagues should count just as much as supporting our patients, but this is not always an easy task. And I don't know if all palliative care teams share the same view. How do you think about this balance?
I can chime in here. I often felt when I was a nurse practitioner in the MICU that I was in the middle, and I was navigating conversations with the ICU attendings and the palliative care team and the nurses at the bedside and the social workers. And so I feel like from a who does palliative care serve, often I felt like for me, like palliative care was serving me because they were helping me navigate a lot of these conversations that were often conflict ridden, and so much of the conversation was getting lost in, quite frankly, people's egos. Like, this is my patient. I know what I'm doing. This person's going to do really well, which was more of the ICU mentality. And then palliative care was really great, I thought, in addition to the chaplains, I think in partnership with the chaplains, in supporting the nurses and the nurse practitioners. So I do feel like, yes, palliative care is serving the patients, but in many cases, they're also really helping to navigate these difficult conversations and management between clinicians.
Mm-hmm. Mm-hmm. Yeah, I see that palliative. I mean, we all see that when we go into a room, it's not just the patients, it's also their families. And then also I come out and I'm palliating the nursing staff, the other providers, people walking down the hall. And I'll end it by saying, I've palliated everybody, right? So education about palliative care is key. As an intensivist yourself, Dr. Hua, what do you see as the best approach to providing critical care teams this education, especially for our colleagues in critical care, keeping in mind the various personalities, egos, and potentially already built-in resistance to palliative care?
Yeah, so I think Craig can also speak to this. Before everybody got on, he was talking a little bit about how he started this palliative care tip of the week thing. And our teams spend a lot of time doing generalist education. And that's also true for the ICU. That has grown in collaboration sort of over time, meaning that I think that we have had more and more education for our trainees, which is really the best time to do it. So all of our critical care fellows do 4 weeks, 2 and 2 of a palliative care elective. And I think that's really critical, really crucial. It's starting to be also the surgery residents, which I think is really great, are doing like mandatory palliative care electives. Mm-hmm. So I think, the harder part is, for our other staff, right? Like the attendings, who may or may not be as receptive. And, I do think that the sort of traditional ways of doing this, to have, say, things like, grand rounds, it's helpful. And I think that's just a baseline. And I think a lot of the other education just actually comes experientially, or the most important education comes experientially with working with each other. And so, I think you kind of at some point reach a critical mass where palliative care can be involved. And, in the ICU, we work from week to week, right? So if you have enough people consulting, even if you have somebody who is
perhaps coming on who's maybe not as excited about involving palliative care, if the consult's already been started by somebody else, right, there's still that continuity, and no one's going to really, once that momentum has been set in play, no one's generally going to be like, we'll go away now. You can't come. So I think that, our team has worked really hard. Our palliative care team has worked really, really hard to gain the trust of all the different groups of people in the ICU. And, I primarily work in a surgical ICU. So it's not just gaining the trust of the ICU physicians, but it's gaining the trust of the surgeons. And that has been a, long sort of work, but it's not really a work in progress anymore, because I would say that I think that trust has really been established and the education has been had. And, when you start seeing your surgeons say things like, oh, I think we need to have a family meeting, I think, right, that you've kind of gotten that tipping point over.
And it's always really good to hear a surgeon say that. So there's emotions.
If I can just add to that, Maureen, too.
Sure, please do. Please.
I think, I think that there's a way in which, the education, it sort of reinforces as our palliative care service develops and matures over time, starting as like a nascent service, getting more into like more of a transitioning into a more mature service. Most of that work is happening is simultaneously with educational interventions, so that we become both more entrenched clinically in the day-to-day activities on different units, and we see that residents and fellows are have gotten some training, either as May was saying, directly, through doing rotations, or maybe more through other means. We have, bi-monthly teachings that we do in the MICUs for our residents in internal medicine, and a number of other teaching activities. And so as folks are, coming through the system and their training, they're getting some exposure to palliative care, either in a clinical way through rotation, or through our consult service, or through a teaching activity, and all of which I think sort of adds to us being more entrenched in the hospital culture, right? And being something like who are you, and what are you guys doing here? We don't need you yet. We're not ready for that. To being more understood conceptually as when we're useful, what is the role, what are the limits, what are the scope of our practice, and so forth, because of that additional exposure and education. So I think they do go hand in hand, actually.
It's interesting how the palliative care micro macro levels, the micro being the patient and family, the macro being everybody else understanding finally what we're doing, and the trust and rapport is built on that grander level as well. So the emotions about this paper, or around this paper, the chaplains on our palliative care team would remind us to ask you, why did each of you seek out this topic? What has happened to you personally or professionally that drew you to share this, to this topic? And then share a case or a story, if you could, please.
Yeah, so I guess I'll start that one. Sorry, I'm actually texting with one of our palliative attendings now. I just got off service and he was helping me with a case, sorry. And giving me a follow-up.
See how entrenched we are? We're even texting when you're on service.
I know, on post-call, no. Well, this was a difficult one, so it was, very, very helpful. I was the first author on this, who's was a medical student at the time. Wendy Tong is now a internal medicine resident at Northwestern University. So she approached me about doing a project, and we were trying to think about something to do with this qualitative data set. And this really came out mostly, actually, very qualitatively, completely from the data, in the sense that when, we read through the transcripts, these descriptions of conflict, and like I have to sort of remind you, and we say in the paper, but I have to remind you that they're actually few and far between. There were so many, like the amount of sort of positive quotes or positive feelings towards palliative care probably, outnumbered the negative ones by 10 to 1 or something like that. However, when you got one that was negative, it was really what we would say in qualitative speak is it was really rich, right? It was very emotion laden, very descriptive. I mean, you could really sort of feel like how, even reading the transcripts, you could feel sort of how affected everybody was from these experiences, and they described it just like it had happened yesterday. And so I think that really for us was really the genesis to say like, wow, there's really something here. And I think, clinically we knew that, right? We know because we've all sort of been in certain conflicts. I have to say, I haven't really been in many conflicts with palliative care physicians, but, conflicts with surgeons, or any kind of sort of interpersonal conflict like that, they kind of weigh on you if they really don't go well. And particularly, it's always super heightened at the end of life. Yeah.
For me, a lot of it is related to some of the more challenging end of life cases that I've seen, both in neurocritical care and in the MICU. And they were always specific, I thought, groups of diagnoses. So all of the people who had really complex end of life care issues related to glioblastoma in the neurocritical care setting. And then in the MICU, the patients who had pulmonary hypertension, who were often very young, and weren't making clinical progress. And then those who are on ECMO for bridge to transplant or bridge to recovery. And I often felt like they were the most challenging cases for me as a nurse practitioner, kind of managing all the different services, keeping lines of communication open with family members, and then obviously making sure that I was addressing all of the sort of to-dos that all the various attendings were asking me to sort of manage. And where I felt like the emotions around this paper really resonated with me was because when these really high stress, complex cases came, I often turned to palliative care, not sort of to say, listen, all this stuff is going on. People have different opinions about what we should be doing, not for them to manage the conflict, but I often felt like they brought this sense of calm in situations where a lot of people had strong opinions about what should be done for the patient.
So, and sometimes we're the ones that have those strong opinions too, and that's where I think this can, as much as we can be a calming force or have a way of maybe soothing some of the challenges that providers have in these situations. Sometimes we bring it ourselves. I know for me, one of the things that I struggle with is my moral obligation to tend to and alleviate suffering. And then that sort of distress that comes up when I feel like I'm not able to, because, that's not what I was asked to do, or, that's not a priority in this particular situation. We're going to get them to recovery. And if you start adding any, Haldol or any kind of, sedatives or anything like that, it's going to not be helpful from our objective. So there was often a tension for me. I remember one case in particular. It was a cardiothoracic surgical patient who had a big a surgery. I forget what the details were, and had recovered from that. And hemodynamically was, after multiple several months of being in the CT-ICU, had recovered at least from a hemodynamic standpoint, infections and so forth. But he was profoundly delirious. I mean, profoundly, to the point, where we were investigating every possible cause of it, and it was refractory to most of our interventions. And so we were really struggling with it. And my sense was, and often, the lens that I look at, from seeing refractory delirium is it often is a harbinger of the very end of life. Yeah. And this was kind of a new idea to the surgeon that we were working with. And he, at the time we had to negotiate, what are we going to do here? Are we going to focus on, and the daughter was almost like begging me to just sedate him and let him just die. And I remember having to negotiate with the cardiothoracic surgeon, and it broke my heart to be like, you don't think he's there yet. Okay. And we're going to send him over to the GI or IR suite for I think it was going to put in a gastrostomy tube to try to feed him. I was like, yeah, I'm not so keen on that idea. And I had to just bite my tongue because I wanted to maintain a relationship, with the surgeon and with the ICU team and so on. He ended up dying the night before going to the IR procedure. And, I ended up writing this up as like a case report suggesting that, when you see refractory delirium in an otherwise stable patient in the ICU, it means something's going on there. It's not normal. And it might mean that he's, for whatever reason, there's something going on, and it might be nearing the end of their lives. And that's exactly what we saw. And so that tension for me, the moral obligation to relieve suffering and the other compelling reasons to, negotiate and maintain good relations with those that are consulting us, was at odds. And so, you have to take the long view here, and recognizing that as a consult service, I wasn't going to go to the mat for in this one particular case, because that might have just severed our relations that we were, very tenuously building over months and months and even years at that point. And so it's a tough one. Sometimes the conflict is real, and you have to choose your battles, or choose how to navigate and soothe as best as you can all the parties involved. So at the end of the day, you can hopefully look at yourself in the mirror and feel like, yeah, I did the best I could under these circumstances.
That's a specialized skill in of itself, choosing all of that. So our last question here is potential solutions, right? If each of you have a magic wand and each of you could make any change, what would you do to improve the existing conflict?
Yeah, okay, I will go first, and hope I don't steal anybody's thunder. But I think if I could have a magic wand, it would be to make clinicians just speak honestly to each other and be able to really listen and hear to each other. I think a lot of the conflict and a lot of the perception of conflict can come when we are not curious enough about understanding where somebody's other point of view comes in. And I do think that at the end of the day, if we allow ourselves the space to believe that, we can really see that everybody actually wants the same thing. We might have different views about how to achieve that, but everybody really does want the best for the patient, right? And I think that we just disagree on how that happens. But I think if we could, with as minimal bias as possible, hear why everybody with their own expertise and with their own sort of body of knowledge and experience, why our sort of routes of what's best for the patient or plans would differ, I think that we'd be able to actually come up with something that really melded together everybody's viewpoint. But it's just so hard because people don't really want to have it's like sometimes people have agendas, right? They want their thing done as opposed to actually truly wanting to collaborate. Right. Even though I think there is totally the space to do that.
Great.
Yeah, I think that's right. And another thing that I would maybe add is, and this is a sort of an old piece of wisdom from, I think it's Atticus Finch says something like this in To Kill a Mockingbird, or it's from somewhere, but you can't really understand someone unless you've walked a mile in their shoes, or crawled into their skin and see things from their perspective. So this idea of perspective taking, right, and being able to really understand as best as you can their perspective, where they're coming from, what their biases are, what they're seeing, what they're not seeing. And I can't possibly do that because I can only know what I'm experiencing and doing and feeling. And but so if I had one magic power, it would be to really to have that full perspective taking and really understand as much as possible the other's perspective. I think that does a lot to really help neutralize conflict, disagreements, because you really are recognizing things from a completely different ground. So it's really, really important to do that the best we can. We try to, by asking people what are they seeing here? Where are they coming from? What are you worried about? What are you concerned about? So a lot of the things that we do actually with patients, we can easily do with our colleagues too. Tell me about what you're worried about when you're looking at this patient, or what concerns do you have, or what are you seeing that I'm missing here, or something like that. So allowing for some more perspective, I think is really healthy in trying to neutralize conflict.
I agree with what both May and Craig have said. I think the other piece to this is having some sort of formal system where the different parties can come together and actually have this meaningful exchange. And we know that time is a scarce resource in the hospital, especially in the ICU. So in the past, when I wasn't working clinically, when I've tried to suggest these types of conversations or meetings happen, I was often met with a lot of resistance. And so really trying to figure out a way to incorporate opportunities or chances for these exchanges to occur within our existing work responsibilities or the workflow, I think might help. Again, that would require buy-in and palliative care, as was suggested by Martin, that palliative care be embedded into teams.
I'm just looking at the questions now. I'd like to open it up, and there's a few comments and questions here in the chat.
I can jump in, Maureen. I was looking at it, so you didn't have to.
Right,
I mean,
thanks.
lots of comments, but most of them are comments rather than questions. So I know we just have like a minute or two left before we let everybody go. So maybe I'll get one last question in, and then we'll send everybody on their way. My question is about trainees. And maybe in particular for Craig, since you train palliative care fellows, but perhaps all of you have a little something to add here, and that's how do you help fellows to acquire these skills? Is it modeling? Do you have like an educational piece? Is there wisdom that you share with them? How are you helping the next generation to be able to have this wisdom in their interpersonal skills?
Great question. Yeah. I think that a lot of different ways, right? There's stuff that we do, debriefing right after the consult, or right after we're seeing a patient or meeting with a team together or a family. So we'll often debrief almost 100% of the time. What was that like for you? What came up for you? What did you notice there? What were some of the conflicts that you might have noticed, and try to draw out some kind of hypothesis in terms of, how do you formulate this? What might be under the surface there that's driving this or that, whether it be in a family or whether it be an attending or whatever. So I think that's a real key piece. I think modeling is another one too. When they see that I'm deferential, or I'm sort of like, backing down on something or negotiating something, they'll see how, wow, if Dr. Blinderman thinks that this is not worth, fighting over, and he's going to try to find another alternative path to a negotiated solution, that maybe that suggests that that's something that they should be doing in the future. And then I think another place in where we kind of unpack a lot of this is in our weekly IDT meetings. So we have as most palliative care teams do, we have a weekly, or sometimes even more, but a weekly IDT meeting where we invite all of our team members, social workers, chaplains, nurse practitioners, physicians, and often other team members too, from ethics and psychiatry and so on. And sometimes even in some of the more challenging cases, we'll even invite the primary team in to help present the case. And so as we're unpacking all the elements that are there, the psychosocial dimension, the ethical dimensions, the clinical dimension, I think our learners see, wow, this is really rich. Like, this is not like a simple, like, just do X and Y. It's like you really have to understand and do some deep reflection. And not just by yourself, but with others, because we all have blind spots, we all have things that we don't see, and so that's where having a team approach, and especially a multidisciplinary team approach, where they can see things, but like, oh, there's some countertransference going on there, or there's some real, you're sounding like you're really distressed about this, or it sounds like the spiritual, component is not there, and we should get chaplaincy in, or whatever. And so you can see how it kind of gives a fuller, richer picture for our learners to be like, this is a lot of work. This is not something you just kind of go in and just think you're going to fix it. It's like, and we struggle, and we put our struggles out there each week.
Great. That's a great way to end. I want to thank Craig, May, and Kamal for your time. Very good paper, very good presentation, and thank you all for joining us. Have a great Friday.
Thanks for having us.
Thanks, everyone.
Bye-bye.
Thank you. Bye.